Welcome back, students, to Decode Healthcare with Harshal. In today's Explainer, part 128 of our masterclass series, we are jumping right into a massive pre-AMDC deep dive. Now, in our last session, part 127, we covered solid organ transplants, right? We looked at the heart, the lungs, the liver, and kidneys. Well, today, we are staying in that elite, top-tier pre-AMDC space, but we're shifting our focus down to the cellular level. We're talking allogeneic and autologous stem cell transplants and the absolutely incredible world of CAR T-cell therapy. But before we get started, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Okay, so here's our roadmap for today. We'll start with MSDRG architecture logic, move into coding stem cells in Section 3, then tackle Section X for new technologies, cover CDI and secondary diagnoses, and finally wrap it all up.
Section 1, MSDRG architecture logic. Let's dive in.
So, to really understand how these high-cost cellular therapies just completely bypass standard routing to land in those top-tier pre-MDC DRGs, like MSDRG-016 for autogenous transplants or 014 for allogeneic transplants, we have to look under the hood at the grouper engine. It's like a giant sorting machine. The system groups thousands of potential scenarios based on clinical and resource similarity. Your key inputs here are your principal diagnosis, your secondary diagnoses, and absolutely crucially for us today, the procedures performed.
And this brings us to a foundational rule. Consider this your first coding bite of the day. If a procedure meets the CMS definition of a major operating room procedure, it bumps the whole case into a surgical DRG partition. This is huge because cellular therapies, even though they're technically infusions, carry massive relative weights. They drive these high-paying, incredibly resource-intensive pre-MDC assignments.
Once you land in that DRG, your secondary diagnoses are what actually dictate your final payment tier. The DRG triplet structure is entirely reliant on your documentation. If you capture an MCC, a major complication or comorbidity, boom, you hit the highest relative weight. If you miss it, you drop down to the lowest payment tier. For these incredibly complex hematologic malignancy patients, missing that documentation means leaving potentially thousands of dollars on the table.
All right, Section 2, stem cells in Section 3.
Let's see how this all translates into actual procedural coding. We're going to focus on how to precisely code the administration of stem cells using the ICD-10 PCS manual. Whenever you're coding an administration, like putting in a therapeutic, diagnostic, or physiological substance, you are going to be working in Section 3. That very first character is always going to be a 3.
Building that specific code requires absolute clinical precision. Step 1 gets us into Section 3. Step 2 asks us for the physiological system. Well, when we infuse stem cells, we are almost always using a peripheral or central vein, which means our second character is a 0 for the circulatory system. But Step 3, the root operation, this is where coders get tripped up all the time.
Listen closely, because this is a massive takeaway. The root operation for administering a stem cell substance, whether that's an autologous harvest to the patient's own peripheral blood stem cells or an allogeneic matched donor transplant, is transfusion. It is not an introduction. Transfusion explicitly maps to character 2 in this section.
Let's contrast these two really quickly, so you literally never get them mixed up. Transfusion is strictly for blood, blood products, or stem cells. Introduction, on the other hand, which uses character 0, is for other therapeutic substances like anti-neoplastic drugs. Getting this single root operation wrong means you're misrepresenting a highly complex transplant as just a standard medication infusion. And let me tell you, that will instantly derail your entire MSDRG assignment.
Moving on to Section 3, Section X, New Technology. Now, you might be wondering, what about the really cutting-edge stuff, like chimeric antigen receptor or CAR T-cell therapy? For those, we actually have to leave Section 3 entirely and jump over to Section X. Section X exists specifically to capture procedures involving incredibly novel technologies that just don't fit into the historical PCS classification. This includes CAR T-cell infusions, like tisagenlecel or axicabtagene ciloleucel, which group to MSDRG-018. We do not use combination codes here, folks. ICD-10 PCS demands we code each distinct procedure to preserve that standardized terminology.
When you're hanging out in Section X, the character meanings shift just a little bit from the standard medical and surgical sections. The most absolutely crucial one to watch is character 6.
This is where you identify the exact new technology, substance being infused. It's this level of precision that allows commercial payers and Medicare to accurately track these hyper-expensive, specialized therapies.
Next up, Section 4, CDI and CC/MCC capture. So, with the procedure codes locked in, we have to turn our attention to the hospital's compliance engine, clinical documentation integrity. For patients undergoing intense myeloablative conditioning and cellular therapies, capturing those secondary diagnoses is do or die. Remember the golden rule. You can't just code a condition from a past medical history list if it has literally nothing to do with the current admission. To legally capture a secondary diagnosis, the documentation has to show it required clinical evaluation, therapeutic treatment, extended the stay, or demanded increased nursing care. If a stem cell patient develops acute graft versus host disease or maybe cytokine release syndrome, the chart must reflect the intense monitoring that follow.
To put that into perspective, look at how powerfully this impacts the facility financially. In a vague scenario, basic pneumonia and uncomplicated diabetes just yields a base weight. But if the physician properly documents sepsis and diabetic ketoacidosis, which is an MCC, the relative weight more than doubles. Now imagine a CAR-T patient who develops grade 3 cytokine release syndrome, or CRS, requiring tocilizumab, or maybe they develop ICANS or veno-occlusive disease. Your queries have to be incredibly sharp to capture that true clinical severity. Otherwise, the facility just eats the cost of that intensive care uncompensated.
But wait, here is a curveball for you. What exactly happens if a patient receiving cellular therapy develops a severe complication, let's say a deep vein thrombosis, after they are already admitted to the hospital?
This is where the present on admission, or POA, indicator steps into the spotlight. If a DVT is flagged with an N for not present on admission, it officially becomes a hospital-acquired condition, or an HAC. And here's the kicker. Even though it is technically an MCC, the grouper engine totally strips its power to increase your DRG payment. The payer is only going to pay the base rate, and the hospital is subjected to a quality review and a potential bundled payment penalty. So, precision in timing is literally just as vital as precision in the diagnosis itself.
Finally, Section 5, Summary and Next Lesson. We have covered a tremendous amount of ground today, navigating the complex structural logic of one of the most advanced high-stakes corners of medical coding. Let's do a rapid-fire recap. The MSDRG system assigns payment based on clinical and resource similarity, right? And that's heavily driven by your principal diagnosis, procedures, and CC/MCC capture. When coding stem cells, remember that Section 3 relies on the root operation transfusion, not introduction. For novel CAR-T therapies, Section X uses character 6 to isolate that specific new tech substance. And lastly, your CDI queries must strictly align with compliance guidelines, proving every secondary condition was actively evaluated or treated.
Well, that brings us to the end of today's deep dive. I want to quickly remind everyone, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Your support is absolutely what keeps this masterclass going strong.
I want to leave you with this final, provocative thought to take back to your teams today. Are your facility's physician queries truly precise enough to defend the immense severity of an allogeneic stem cell or CAR-T case during a strict payer audit? Really think about your documentation for complex conditions like GVHD or CRS. Next time, in Part 129, we are jumping into another intense pre-MDC deep dive, looking at tracheostomy mechanics, prolonged mechanical ventilation over 96 hours, and weaning protocols. You definitely won't want to miss it. See you in the next lesson.